Today our topic is secondary hemostasis and related disorders. Secondary hemostasis stabilizes the weak platelet plug through the coagulation cascade. Coagulation cascade generates thrombin which converts fibrinogen in the platelet plug to fibrin. Fibrin is then cross-linked, yielding a stable platelet fibrin thrombus. Factors of the coagulation cascade are produced by the liver in an inactive state. Activation requires exposure to an activating substance. Tissue thromboplastin activates factor 7 extrinsic pathway. Subendothelial collagen activates factor 12 intrinsic pathway. Phospholipid surface of platelets. Calcium derived from platelet-dense granules. Disorders of secondary hemostasis, usually due to factor abnormalities. Clinical features include deep tissue bleeding into muscles and joints, hemarthrosis, and rebleeding after surgical procedures, for example, circumcision and wisdom tooth extraction. Lab studies include prothrombin time (PT), Meyer's extrinsic factor 7 and common factors 2, 5, 10 and fibrinogen pathways of the coagulation cascades. Partial thromboplastin time (PTT), Meyer's intrinsic factors 12, 11, 9, 8 and common factors 2, 5, 10 and fibrinogen pathways of the coagulation cascade. Hemophilia A. Genetic factors 8, B8, F8 deficiency, X-linked recessive predominantly affects male. Can arise from a new mutation de novo without any family history. Presents with deep tissue, joint and post-surgical bleeding. Clinical severity depends on the degree of deficiency. Lab findings include more PTT, normal PT, less F8, normal platelet count and bleeding time. Treatment involves recombinant F8. Hemophilia B, Christmas disease. Genetic factor 9 deficiency. Resembles hemophilia A except F9 levels are decreased instead of F8. Coagulation factor inhibitor. Acquired antibody against a coagulation factor resulting in impaired factor functions. Anti-F8 is most common. Clinical and lab findings are similar to hemophilia A. PTT doesn't correct upon mixing normal plasma with patient's plasma. Mixing study due to inhibitor. PTT does correct to in hemophilia A. Von Willebrand disease. Genetic von Willebrand deficiency. Most common inherited coagulation disorder. Multiple subtypes exist, causing quantitative and qualitative defects. The most common type is autosomal dominant with decreased von Willebrand levels. Presents with mild mucosal and skin bleeding. Low von Willebrand factors impairs platelet adherence. Lab findings include more bleeding time, more PTT, normal PT, decreased F8 half-life. Von Willebrand factor normally stabilize F8. However, deep tissue, joint, and post-surgical bleeding are usually not seen. Abnormal Ristocertin test. Ristocetin induces platelet aggregation by causing von Willebrand factor to bind platelet (GPIB). Lack of von Willebrand factor impaired aggregation abnormal test. Treatment is desmopressin ADH analog, which increases von Willebrand factor release from the weibel palette bodies of endothelial cells. Vitamin K deficiency disrupts function of multiple coagulation factors. Vitamin K is activated by epoxide reductase in the liver. Activated vitamin K gamma carboxylates factor 2, 7, 9, 10 and proteins C and S. Gamma carboxylation is necessary for factor function. Deficiency occurs in newborns due to lack of GI colonization by bacteria that normally synthesize vitamin K. Vitamin K injection is given prophylactically to all newborns at birth to prevent hemorrhagic disease of the newborn. Long-term antibiotic therapy disrupts vitamin K producing bacteria in the GI tract. Malabsorption leads to deficiency of fat-soluble vitamins including vitamin K. Other causes of abnormal secondary hemostasis: liver failure, decreased production of coagulation factors, and decreased activation of vitamin K by epoxide reductase. Effect of liver failure on coagulation is followed using PT. Large volume transfusion dilutes coagulation factors resulting in a relative deficiency. Other disorders of hemostasis: heparin induced thrombocytopenia, platelet destruction that arises secondary to heparin therapy. Fragments of destroyed platelet may activate remaining platelets leading to thrombosis. Disseminated intravascular coagulation, pathologic activation of the coagulation cascade. Widespread microthrombi results in ischemia and infarction. Consumption of platelets and factors results in bleeding, especially from IV sites and mucosal surfaces. Bleeding from body orifices. Almost always secondary to another disease process. Number 1. Obstetric complication. Tissue thromboplastin in the amniotic fluid activates coagulation. Number 2. Sepsis, especially with E. coli or and meningitis. Endotoxins from the bacterial wall and cytokines, for example TNF and interleukin 1, induce endothelial cells to make tissue factor. Number 3. Adenocarcinoma. Mucin activates coagulation. Number 4. Acute promyelocytic leukemia. Primary granules activate coagulation. Number 5. Rattlesnake bite. Venom activates coagulation. Lab finding includes less platelet count, more PT and PTT, less fibrinogen, microangiopathic hemolytic anemia, elevated fibrin split products, particularly D-dimers. Elevated D-dimer is the best screening test for DIC, derived from splitting of cross-linked fibrin. D-dimer is not produced from splitting of fibrinogen. Treatment involves addressing the underlying cause and transfusing blood products, and cryoprecipitate contains coagulation factors as necessary. Disorders of fibrinolysis. Normal fibrinolysis removes thrombus after damaged vessel heals. Tissue plasminogen activator converts plasminogen to plasmin. Plasma Plasmin cleaves fibrin and serum fibrinogen, destroy coagulation factors, and block platelet aggregation. Alpha 2 antitrypsin inactivates plasmin. Disorders of fibrinolysis are due to plasmin overactivity resulting in excessive cleavage of serum fibrinogen. Examples include radical prostatectomy, release of urokinase activates plasmin. Cirrhosis of liver, reduced production of alpha 2 antiplasmin, presents with increased bleeding, resembles DIC. Lab findings include more PTT, plasmin destroys coagulation factors, more bleeding time with normal platelet count. Plasmin blocks platelet aggregation, increased fibrinogen split products without D-dimers. Serum fibrinogen is lysed, however, D-dimers are not formed because fibrin thrombi are absent. Treatment is aminocaproic acid which blocks activation of plasminogen.